introduce our speaker, who I've had the wonderful opportunity to meet recently, and was just really kind of blown away by her knowledge and experience, and really just her compassion for working with individuals with disabilities in general, and then her knowledge about brain injury as well. So with us today, we have Dr. Angela Gabella. She is a board certified functional neurologist, a licensed chiropractor, and fellow of the American Board of Brain Injury and Rehabilitation. She has completed additional postdoctoral specialties training in clinical neuroscience, childhood developmental disorders, traumatic brain injury, and vestibular rehabilitation. She is currently has her own practice in Raleigh, North Carolina at Precision Brain Center. So without further ado, I'm going to turn it over to Angela. Thank you guys so much for attending, and I'm excited to learn more about this topic.
Hi, Lauren. How's the audio? Can you hear me well?
Yep, sounding good.
Perfect. Okay, we'll go ahead and hit the ground running with this. Okay, so Lauren went ahead and introduced me. Again, I'm a board certified functional neurologist. I have a bachelor's of science degree in molecular biology and microbiology from UCF. I've completed my postdoctorate studies at the Carrick Institute and a fellowship under the clinical expertise of Dr. Frederick Carrick. I was a resident clinician at the Carrick Brain Center prior to opening my practice, and like Lauren had mentioned, my practice is currently located in Raleigh, North Carolina, and it's called Precision Brain Center. I have extensive experience in managing complex neurological disorders and have treated many Olympic and professional athletes. Okay, so I just want to briefly give a big thanks to Dr. Carrick, because he is the pioneer and leader in the field of functional neurology. So a lot of the things I'm going to cover today are due to the dedication and work he's really put into the field. So he is the founder of the Carrick Institute for Graduate Studies and professor of clinical neurology. He's a senior research fellow at the University of Cambridge in UK. He has a PhD degree from Walden University. He has a master's of science degree from Harvard. He has attended high-profile professional, Olympian, and collegiate athletes from around the globe that have suffered from brain injury over the past 4 decades. Dr. Carrick serves as a Dean of Education at the Carrick Institute and has published his research in Index, PubMed, and U.S. National Libraries of Medicine. So here again is Dr. Carrick, and he has actually assembled the world's largest database of dynamic computerized posturography outcomes related to TBI, neurodegenerative diseases, neurodevelopmental disorders, and movement disorders collected from thousands of patients across the globe that were treated using a multimodal neurological rehabilitation approach known as functional neurology. So down here below, you'll see some of the research publications that he's been indexing, which is gait and posture, neurorehabilitation, and you can kind of read through these. We do have a lot to cover, so I apologize for speaking a mile a minute. I just want to get all these gems out to you guys. So this is just some pictures showing over here to the right is Dr. Carrick and Sidney Crosby. He's a big name in the hockey world. He was the captain of the Olympic hockey team, and he's a 2-time Golden Globe medal winner. And so in terms of barriers that it takes for people to actually get proper treatment after a brain injury, a lot of it is because the field is so fairly new, and for the past 50 years ago, concussions weren't really being treated. You were just getting prescribed rest and return to play, and legal dictation of how to care for these patients wasn't really out there. But as soon as you start seeing NFL come out with chronic encephalopathy and things like that, and you get professional athletes being treated, the awareness becomes it's in the social media, it's on TV, so it's a really big deal, and it's hope for things progressing forward. So this to the left is just a picture of Dr. Carrick and his research team at Harvard. We're going to go through some of the research that he has published. At the bottom is grand rounds at the Carrick Institute, and you'll see all these clinicians that come in from everywhere to help treat patients from around the globe. All right, so we're going to jump in just to defining and explaining what functional neurology is. So what makes functional neurology different from conventional treatments? There are a lot of neurological conditions that once diagnosed have no conventional medical treatment, or the treatment options are often ineffective. That's where our functional neurologists can play a huge role in the integrative care of complex neurological disorders. Most neurological disorders have problems with the way their nervous system processes, integrates, and communicates information. They oftentimes do not have true pathology or an ablative lesion, yet they still suffer from symptoms due to their brain's functional deficits. Conventional medicine is necessary for treating ablative brain pathology, but lacks efficacy in diagnosing and treating functional neurological deficits, which are seen in mild traumatic brain injuries and concussions. Functional neurologists oftentimes see the patients that don't improve with other treatment options. Functional neurology is a new field and often unknown to the average population. Medications are typically very limited in treating neurological disorders. Drugs and supplements don't have the ability to selectively bind to one receptor site in the brain and therefore can cause more side effects than improvements. Symptoms can often worsen or become masked by medication. Meanwhile, neurodegeneration and neuron diastasis continues to occur, resulting in further brain dysfunction. So functional neurology is a cutting-edge approach to neurological rehabilitation. A functional neurologist approach is utilized to manage chronic neurological disorders. Our goal is to stimulate your brain's natural capacity to grow new dendritic connections and change, enabling you to achieve optimal mental, emotional, and physical performance, as well as improve your quality of life. The brain receives inputs from all sensory systems and must use the information efficiently to accurately orchestrate meaningful responses. When the brain cannot interpret and integrate the information it receives, this results in an inaccurate map of the environment and an inability of the person to function well in it. All right, so we're going to talk a little bit about neuroplasticity, because when you do make changes in the brain, they're positive changes, it happens through a process known as neuroplasticity. So through the application of functional neurology and the principles of neuroplasticity, we provide brain-based stimulation and brain rehabilitation procedures to patients with a variety of complex health conditions. Restoration of brain health is achieved by a process known as neuroplasticity, or the brain's ability to adapt, change, and grow stronger when the proper stimulus is provided. Scientific research and extensive evidence has made neuroplasticity a widely known concept. How eye movements, vestibular activation, and somatosensory stimulation has a major impact on remapping brain function. Our approach to neurological rehabilitation puts a heavy emphasis on creating precision and accuracy within the vestibular networks and brain structures that control eye movements. These specific pathways travel through the entire brain and activate almost all surrounding structures. So I want you to take a look at this picture that I have over here on the right side. And the reason being is the sentence here that I just read about specific pathways traveling throughout the entire brain. If you look, you notice that this is the vestibular apparatus. It's a peripheral apparatus in your inner ear, and it senses gravity constantly, and it tells the brain centrally where we are in space. Well, when it fires in, it's going to go into the brainstem area right here. You also see these two names, pursuits and saccades. These are terminology that I will review in the next slides, but it's a type of eye movement. So the nuclei that house the control of those eye movements are here in the brainstem. Then the brainstem takes those sensory systems. So brainstem is considered more of our primitive reflexive control of things, and it's going to fire up pathways into the cortex. So if you look over here, you see the cortex. The cortex is always considered phylogenetically how we've evolved as a human species, meaning the cortex is going to control higher up human function, cognition, memory, emotionality, our personality, who we are as people and individuals. So you notice these names of areas in the cortex, the frontal eye field that's involved in volitional saccade generators. Then you have supplementary eye fields, you have the parietal lobule, that's going to have maps of our body parts in the parietal lobe. Then back here is where the occipital cortex would be, and that's going to be very much involved in vision and visual motion and stuff. This area here, the dorsolateral prefrontal cortex, it's super important, and a lot of my research today that I'm going to present is going to reference this dorsolateral prefrontal cortex. But I just want you to get a good picture understanding from the beginning before we kind of hit the ground. All right, so the surrounding structures often carry out higher cortical functions such as memory, cognition, personality, social inhibition, and emotions. Cognition, emotions, and personality may seem completely unrelated to eye movement and maintaining balance, but in reality, they are linked by numerous overlapping pathways. The hardwired overlap between eye movement pathways and the vestibular system to all other human functions is what allows us to harness neuroplasticity and directly activate under-functioning brain structures. Okay, definition of terminology. So the vestibular system, like I showed you in that picture before, is a sensory system that provides a leading contribution to the sense of balance and spatial orientation for the purpose of coordinating movement with balance. The vestibular apparatus is located in the inner ear and is affected by gravity. The vestibular ocular reflex involves the ocular pathway and vestibular pathway, so it is very powerful for remapping brain function and post-concussion syndrome recovery. When we say the word ocular, you want to think eye. It's always going to be referring to something to do with the eyes. Ocular motor refers to something that is movement of the eyes. Then we have an area called the oculomotor nuclei. That's the cranial nerve 3 that innervates most of our eye muscles. And then there's going to be a research article that I refer to head-eye vestibular motion therapy. That type of therapy has the ability to fire into every brain structure. This type of therapy consists of eye movement training, head movements while fixating on a target with the eyes, the vestibular ocular reflex, full body rotation, and various combinations of eye movement and head motion stimulating the vestibular system. So terminology of eye movements. So like I referred to before about saccades and pursuits, a saccade is an extremely fast, voluntary, or automatic. Automatic means like a reflexive type of movement of the eyes, allowing people to accurately refix on an object in the visual field. A saccade is a type of eye movement classified by a fast jumping motion of the eyes to objects or targets in the visual field. A pursuit eye movement is very different than a saccade. It's a smooth tracking or following of both eyes. So like if somebody were to walk in front of you and you follow that, or a bird flies up in the sky and you follow that bird in the sky, that's a pursuit. Whereas if you're looking straight ahead and something moves in your periphery and you go and look at it really fast, that would be a saccade. Okay, so this is a video of a unilateral vestibular deficit. It's going to explain what the VOR is. So the VOR is the vestibular ocular reflex. When the head moves one direction, so if the head moves to the right and somebody's looking at a target straight ahead, the eyes have to move opposite and equal to the head. So the eyes are going to move at the same velocity and they're going to land in the same position as the muscles of the neck would move the head, and it's going to go to the left side. So let's just go ahead and watch this video. I'm going to explain it as he goes through. So this patient has a deficit when going to his left side. So if you notice when the head moves, the head is going to move to the left here. And there's a fast refixation correction. This video is not coming in so great. Lauren, were you able to see clarity of this video?
Yeah, I can definitely see the movement of the head from one side to the next a little bit jumpy, but I think it was good.
Okay, perfect. So if you miss what was happening here, to one side, I believe to the left side, when his head moves to the left side, his eyes should not have any refixation saccade. They should stay dead still if the VOR was perfect. But in a deficit, it's not perfect. So what you see is the eyes have a recorrection saccade back to center because they fall off of target. So the summary of this was just so that you can see that the head moves one way and the eyes go opposite. That's the vestibular ocular reflex. And moving on, so now we're going to jump into some of the research. So the most current and relevant research on treating TBI patients references the role of the dorsolateral prefrontal cortex. In all symptomatic concussion and TBI patients, what brain structure shows decreased activation on fMRI? And the answer to that question is the dorsolateral prefrontal cortex. The decreased activation in the dorsolateral prefrontal cortex is responsible for the symptoms TBI patients experience. Upon symptom resolution and recovery, the dorsolateral prefrontal cortex appears to resume its normal function. That's huge because it's saying that this cortical area in all concussion patients that still suffer symptoms it's going to show a decreased activation pattern. So that means that should really be a target area for us to use as treatment modalities. So here is the first article we're going to cover, and it's recovery from mild head injury in sports, evidence from serial functional magnetic resonant imaging studies in male athletes. So what they used in this experiment as an outcome measure is a memory task using verbal and visual memory. So that's what they tested these athletes, and then they hooked them up to an fMRI, which measures cerebral blood flow. So it tells you what areas are actually lighting up and using blood. So those are the areas that would be activated. So the results of this study, all symptomatic concussion athletes initially showed atypical brain activation patterns in the dorsolateral prefrontal cortex compared to the initial post-injury evaluation. Those athletes at follow-up with post-concussion symptoms resolved showed significant increases in activation of the left dorsolateral prefrontal cortex. Concussed athletes whose post-concussion symptoms status remained unchanged, which means they were still suffering the same symptoms, at follow-up continued to show atypical activation in the dorsolateral prefrontal cortex. Healthy athletes showed remarkably clear and consistent brain activation in the dorsolateral prefrontal cortex initially, as well as in follow-up, highlighting the test-retest reliability of fMRI. So if you take a look over here in study 1, this is a picture of the post-concussion improved group, meaning in study 1, they were symptomatic. So their post-concussion scores were high up there. And so what you see is an area in the temporal lobe here lighting up, but you do not see the dorsolateral prefrontal cortex being activated. Now, study 2, this group of concussion athletes were no longer symptomatic. So they had recovery and they no longer needed the compensatory mechanism. So you don't see a light up over here, but you see the activation of the dorsolateral prefrontal cortex resume its normal function. So decreased activation in the dorsolateral prefrontal cortex are shown on fMRI in all brain injury and concussion patients with symptoms despite normal scores on memory tasks. So all these athletes basically perform just about the same on memory tasks, regardless of them still having symptoms. Athletes in the post-concussion symptoms improved group had an initial activation in the left temporal lobe that was not seen in the control group. Upon symptom resolution and recovery, the dorsolateral prefrontal cortex appears to resume its function. Compensatory mechanisms no longer being required to carry out the task, and activation of the left temporal lobe no longer appears on fMRI. Along with the presence of the post-concussion symptoms, there is an initial functional deficit in the prefrontal cortex and concurrent recruitment of other brain regions as a compensatory mechanism to carry out the task. This would explain the normal behavior performance and scores on working memory tasks shown by the concussed group in spite of the presence of symptoms. Oop. Okay. So correlation of decreased activation in the dorsolateral prefrontal cortex as a cause of the symptoms experienced in the population of post-concussion symptom patients suffering from symptoms despite normal memory task scores. So take a look at this picture diagram down here. It does a great summary. I know a lot of the research is very difficult for people to look at. Even scientific research, it's hard to understand and read it. It's heavy and dense. So I'm hoping that breaking this down to take home points really offers some hope for people in terms of getting better and improving. So that's why we're kind of going through this. So this first fMRI is healthy controls, and you see both study 1 and study 2 are about the same amount of activation, and they're using that dorsolateral prefrontal cortex. Now in the center, you see the concussion group that had improved symptoms in study 2. So initially, they don't show any activation in the dorsolateral prefrontal cortex. Their symptoms improve. Here's their score down here. So it was initially 37.5, and then it improved. So then they have a 9.5, meaning their symptoms decreased. And they returned to activating the dorsolateral prefrontal cortex. So now keep in mind, even though they show different brain activation patterns, these athletes in study 1 and study 2 did about identically the same on this working memory task that they were testing. So the hard thing is you have a patient come in and, you might do certain tests with them and they might seem okay, but they're actually using this compensatory mechanism to carry out a task. Well, in the future, what that leads to is just major global deficits where you're never getting better. You continue to get worse and worse. Now, looking at this third group population was the concussion that did not improve, meaning in study 1 and study 2, they were symptomatic in both cases. Study 1, their score was 31.6, and then study 2, their score was 37.4. So they continue to use this left temporal lobe as a compensatory mechanism during this working memory task. So study 2, post-concussive symptoms not improved. The left dorsolateral prefrontal cortex, where one would expect to detect brain activation given the working memory demands and the verbal nature of the stimuli, did not show significant activity. Okay, next really great article that I wanted to bring to your attention and kind of break down. It's called The Role of the Human Dorsolateral Prefrontal Cortex and Ocular Motor Behavior. So ocular motor means the control of eye movement, basically. So since all symptomatic brain injury patients have decreased activation in the dorsolateral prefrontal cortex, what therapies or forms of stimulation can be used to increase the activation in the dorsolateral prefrontal cortex? So the answer to that question would be eye movement exercises, complex memory guided saccades, anti-saccades, and no-go cognitive eye-hand coordination saccade tasks all activate the dorsolateral prefrontal cortex. I know these words seem very, very heavy, but I'm going to show you videos of these different tasks being played out with patients and stuff to help you grab it and understand how things can be implemented at home. In this abstract of the article, the areas that I want you to take note of is the dorsolateral prefrontal cortex is involved in the preparation of saccadic eye movements. The dorsolateral prefrontal cortex has direct connections with the main cortical ocular motor areas, that is with the frontal eye field, supplementary eye. It goes on to list some of those cortical areas I actually pointed out in the original brain diagram we talked about a few slides ahead. And the anti-saccade paradigm has shown that the dorsolateral prefrontal cortex is involved in the inhibition of unwanted reflexive eye movements. The dorsolateral prefrontal cortex also controls short-term spatial working memory involved in memory-guided saccades. I'll show you what those are. And the dorsolateral prefrontal cortex is involved in the preparation of predictive saccades made before the appearance of an unexpected target. Saccade sequences are therefore also control some aspects of temporal working memory. These different functions suggest that the dorsolateral prefrontal cortex plays a major role in the decisional processes governing ocular motor behavior. So what this is telling us is that if we do these eye movement therapies, it's going to have a high probability to feed up into this dorsolateral prefrontal cortex network, activate it, increase the activation pattern. Once you do increase that activation pattern, the likelihood of having symptomatic resolution of depression, brain fog, headache, cognitive decline is very, very high. So we can't really measure those subjective symptom scales. We can only ask the patient, hey, what are you experiencing? But what we can measure these accuracy of eye movements, and we can also use it as a therapy. So it's really exciting stuff. So I love this diagram. It paints a great picture of what we're going to continue to talk about. How the dorsolateral prefrontal cortex can be activated by saccades and ocular motor exercises. So if you take a look right here, this area is the dorsolateral prefrontal cortex. And they talk about how it's involved in this decisions regarding inhibition, prediction, and selection of targets. Short-term spatial memory, temporal working memory. Well, that's really important because what do we see all the time in an aging brain, in Alzheimer's, dementia? The short-term memory is out the door. It degenerates, meaning there's a lot of brain integrity going on involved in working memory, short-term memory, spatial memory. And it's really important for who we are as people. Now, if you look over here, we have the pre-supplementary eye field, which is involved in motor learning. We have the supplementary eye field, which is involved in motor programming. The frontal eye field is really important for intentional saccade triggers, meaning I volitionally want to look at a target on a video. So this is one area. Now, I want you to compare this to an area that's in a whole different section, and it's over here. And this is right at the junction of the parietal and occipital lobe, but this is important for your reflexive guided saccades. So a reflexive eye movement and a volitional eye movement ends up having a very different impact in the brain. And that's where it gets marvelous and just a passionate experience when you're treating a patient, because each exercise is very intricate and very specific to their needs. And then you can progress treatment up as you go and the patient gets better. So in the back here, we know that the occipital lobe is involved in vision, but it's also involved in intentional motivation, visual spatial attention, visual spatial integration. And then these pathways, if you notice, they're all constantly communicating to each other. It's not like one area just says this and that's all it does. No, the networks of the brain and the human mind is just so complex and intricate that it's it's wonderful. It's magic stuff. So if you look down here in the temporal lobe, we're also dealing with medium-term spatial memory and long-term spatial memory. So those are the areas we know just go down south, and the cortical area degenerates where we can see on scans in Alzheimer's and dementia that the temporal lobe and amygdala have atrophy. Okay, so we're going to move on. We're going to go into another article. This is actually published by Dr. Carrick and his research team, and this is called Head-Eye Vestibular Motion Therapy Affects the Mental and Physical Health of Severe Chronic Post-Concussion Patients. So this is a big deal because we're going to look at the population of the most severe chronic patients that didn't respond to other treatments. All subjects in this study had severe debilitating symptoms that lasted longer than 6 months. Most post-concussion patients had been treated with a variety of combination of standard medical treatments, such as rest, physical therapy, rehabilitation, and pharmacy without successful resolution of symptoms. Head-eye vestibular motion therapy for a 5-day duration is associated with statistical and substantive significant decreases of symptom severity scores associated with chronic post-concussion syndrome. The changes in mental health and physical symptoms after head-eye vestibular motion therapy in post-concussion syndrome patients suggest that this therapy might have applications in other mental health scenarios. Really big deal because the rate of depression and emotional disturbances are just increasing by the day. It's very problematic. So having implications in mental health, that's a big deal for us. Patients report a significant decrease in their symptoms and an increase of function after head-eye vestibular motion therapy. So going on to talk about this just a little bit more, how head-eye vestibular motion therapy and remapping accuracy of saccades can relieve depression, memory decline, irritability, and sleeping disorders. So irritability and sleeping disorders were the greatest predictor of total symptom severity score. So that means if a patient's suffering from irritability and sleep problems as well as memory difficulties, we want to be concerned. We want to know that we got to work really hard to get this patient better because those aren't good indicators. The great news about this study is this next sentence here I'm going to go over. The treatment outcomes are dependent upon receiving the treatment and not the subjective or objective findings before the treatment. So what this is saying is that how the patient resolves and the outcomes and prognosis of their treatment is not dependent on how terrible they feel, their symptoms, which is the subjective scale, or how terrible they did on the physical exam findings, which is the objective scale, but rather it's dependent on them actually receiving treatment. So it really gives hope to so many people that are like, I've lived with these symptoms for 10 years. I don't know what to do. It's keep getting worse. So your outcomes is not dependent on how terrible you feel, but rather dependent on you actually getting treatment. So there's a high, so now we're gonna march on with some more deep stuff that I'm going to explain. There's a high probability that increasing the accuracy and speed of saccades, which are fast eye movements, and improving gaze stability translates into improved cognition, memory, and concentration. Limbic and emotion, which is emotional stability, and emotional performance or motor performance, which is balance, posture, and gait. Gait refers to the walking, how it takes our cortex. Our cortex actually controls the human gait pattern where we swing the opposite arm every stride length we strike. So that when I refer to gait, we're talking about walking. Eye movement and head-eye vestibular motion therapy can facilitate neuroplasticity and stimulate neurons to grow new dendritic connections in the basal ganglia and cortex, which are the same neuron groups that control many of the symptomatology that post-concussion patients suffer from. So this slide here I created because I really wanted to give you guys a visual reference of what we're talking about here. So how eye movement exercises can remap connections that are reduced in patients with depression, emotional issues, and cognitive decline, deficits, and memory decline. So over here to the left side, we're looking at 3 overlapping circuits in the basal ganglia. The red one is our motor circuit. So it's going to control our balance, our muscle tone, our gait patterns. People that have movement disorders or dystonia, they're going to have problems in this circuit. Now, cognition is going to be our memory, how intelligent we are, how well we're able to string our thoughts together. And that's going to be this green pathway here. And if you notice, this is involving overlapping nuclei. These are all the exact same nuclei, but they control 3 very different functions of humans. This bluish purple one is the limbic network, and it's going to be firing up to the hippocampus and amygdala. Now, if you look over to this right side, we're going to take a look at what the superior colliculus is. I've highlighted where the basal ganglia is. These are explaining the different nuclei of the basal ganglia, but over on this diagram, this is the basal ganglia, right? So we have the superior colliculus. The superior colliculus houses excitatory and inhibitory burst neurons for saccades. It's literally the nuclei that generates saccadic eye movement. So it's a real big deal when we're talking about eye movements. So the superior colliculus is going to come down and it's going to fire right into the basal ganglia, meaning if we do saccades and we do saccades at a correct velocity and accuracy, we are going to remap areas of the basal ganglia that are involved in limbic, cognitive, and motor pathways. So velocity and accuracy of saccades, fast eye movements, are controlled by the superior colliculus, which projects to the same areas of the basal ganglia that control motor, cognition, and emotions. So the idea that you can literally give an eye movement exercise to a patient, very specific to what they need at that time, and they come in and they say, I'm really depressed, or my memory is terrible, it's going downhill. And so instead of maybe doing counseling or things like that, to think that an eye movement and remapping and making it accurate literally will translate into them having a much more enjoyable life, increased happiness, their memory being much sharper. That's a real big deal because this stuff is non-invasive, you know, there's no harm type of thing, which is fantastic. Okay, so another research article, I'm just going to run through this really quickly. This is published by Dr. Carrick, but I really wanted to bring this to everybody's attention because we used to previously think that stroke was an ablative lesion, and if you have a stroke, there's nothing you can do. Well, that's wrong because there's a lot you can do. So this article is titled "Eye Movement Training Results in Changes in QEEG and NIH stroke scales in subjects suffering from acute middle cerebral artery ischemic stroke, a randomized controlled trial." So the result of this, the oculomotor function was more sensitive in identifying cognitive dysfunction and improvement compared to the NIH-SS and MRS stroke scales. That's massive because that's saying that if you measure oculomotor function, that's the eye movement function, you have a better indicator of how well their cognition is versus these stroke scales that have been the medical standard for years. The authors concluded that oculomotor assessment demonstrates cognitive effects of even mild stroke and may provide improved quantifiable measurements of cognitive recovery post-stroke. So just to go through some of these key points I pointed out, standardized objective examination of eye movements is of great value in the detection and clarification of subclinical lesions in the central nervous system. Patients with multiple sclerosis with lesions beyond the primary visual field have both saccadic latencies and smooth pursuit abnormalities of ocular motor dysfunction. Patients suffering from mild closed head injuries also demonstrate prolonged saccadic latencies. Quantitative tests of oculomotor function are sensitive markers of cerebral dysfunction that can assist and direct patient assessment. A cerebral vascular lesion in the right or left hemisphere produces a general slowing in the saccadic latency and reduced accuracy of saccades with respect to healthy subjects. Abnormalities in the control of saccades have been described in patients with cerebral pathology, suggesting that they might be robust biomarkers that could be utilized in guiding and interpreting treatment outcomes. So I'm going to show you this video of a stroke patient, and it's just going to show her doing saccades. You're going to notice that there's a general slowing to the contralateral side of the cerebral stroke. This patient has a right cerebral hemisphere infarct, and you'll see the SCODs to her left, away from the side of the lesion, are usually hypermetric and slower. Now, to tie this into treatment, so increasing the velocity and accuracy of left saccades in a patient with a right cerebral stroke would create positive neuroplasticity, stimulating new neuron connections where the stroke occurred. And also, you have a high probability of helping her with whatever symptom, if it's cognitive decline, if it's emotions, if it's a paralysis of a limb. So I'm going to go ahead and just play this video, maybe. Yeah. So she's looking over to the right. The right is of general speed, it's fine. Now when she looks to the left, much slower, huh? And the layman person can see that, you can pick up on it, and you can know, okay, yeah, that's not right. A lot slower, and you also see a little double step at the end. She's hypometric. So that's what that looks like. And that's also what a saccade is. Okay, so the other thing I want to bring up is I constantly keep talking about these eye movements and doing it for treatment. And the reason being is we have quantifiable measurements of eye movements. Whereas a patient comes in and tells me they're depressed, or tells me they have memory decline, or tells me they're having problems with getting the right words out and things like that, I can't quantify. I don't have a measurement that can put a number on that symptom, right? But if I know that those functions in the human cortex, they also control eye movements, and I know that I can measure eye movements and I can quantify it, that's a really good biomarker to say, okay, I have a high probability of getting this patient better by doing this. And it also gives me a way to go back and remeasure their eye movements and say, did I make a change? Did I make them better? Did I not do anything at all, or did I make them worse? So I like very statistical stuff that says there's no guesswork involved. I want to do what's right for the patient, type of thing. So in this graph, this is just, we're just going to summarize this really, really fast. So this is something similar you would see on a VNG graph of a saccade. And when you look right here, this A, this B, this C, that's the target location. So this graph here is the eye motion. So if I'm having a right saccade, the upward direction is going to indicate a right saccade. So if I have a right saccade to a target that's to my right side, I want to land right on this dotted line. But you see in this patient, they don't land on the dotted line. They actually go past the dotted line. And then they have a recorrection saccade trying to get back to the target. So that's called a hypermetric saccade. And so that's what that would look like. So square wave jerk is another very common feature in brain pathology. And some of the patient videos I have ahead, you'll see square wave jerks happening. But what that means is when the eye should be still and they should be sticking on this target right here, the patient has these non-volitional, meaning it's just happening. They can't really inhibit it, where their eyes are jerking off the target and then pausing for a moment and coming right back on. So if you notice here, it jerks to the right, it pauses for a millisecond, and then it has a left jerk to try to get back to the center fixation. So this is just an example of measuring these eye movements. And now we're going to get into patient cases. So I want you guys to just sort of get the global idea of the functional neurology approach to patient care, and try not to worry if there's a bunch of big words that are like crazy, and it's not, you're not going to get tested on this. To just kind of create a good clinical picture for you guys. Okay, so patient number 1 is diagnosed with MS, and she's had it for the past 30 years. So this patient actually has a very atypical presentation of MS. She's very sharp cognitively, but she has not been able to walk or get around without a walker for the past 10 years. She's got a real spastic paraparesis in her hip flexors and legs. So to even roll on a table, she doesn't have much motor control of her lower legs. I'm going to go ahead and play this video, and there's a couple things I want to point out to you while we play this. Okay, here I ask her, and she's going to look to the right, and she's going to hold this here. She gets a little end gaze and nystagmus to the right. It's no big deal, fairly normal. The biggest thing I'm going to have you guys notice is when she looks to the left, she actually has a left visual field hemi-neglect. So she's supposed to be looking to the left here, and you see this large lateral pulsion to the right because she doesn't like looking to the left. She doesn't do well attending over there. And she's having this constant jerk. See, she's having the constant jerking motion away from that left field. So what that means to me is throughout this whole entire eye movement video, I see that she has a predominance of a left square wave jerk, meaning she has these fast eye motions that shouldn't be there to the left. And then when she goes to look to the left field of view, she has an inability to hold gaze over there, and she has that hemi-neglect. She also has decreased activity coming from that right cortical hemisphere. If you take a look here, you notice that her pupil is much larger on this right side versus this left side. That shouldn't be happening when there's no light. I mean, it shouldn't even be happening when there is light, but to have that tonic imbalance between sympathetic and parasympathetic tones of her pupils, that's a real big deal. And so that's indicative that there is a decreased right frontal cortex activity that is meant on this right side. That cortex is meant to fire down and inhibit the IML, the ipsilateral IML. So that area is involved in sympathetic output. So from my mind, what I'm trying to translate to you guys is I look at these eye motions and I take much more from it than just, oh, it's an eye motion, it's accuracy. There's so many neurological structures that are involved in this. So when I look at eye movement, I'm able to say, okay, we've got to hit this area first, this area second. She does really well in this area, so I'm going to use that pathway to fire into something that she doesn't have so well. So patient 1, eye movement video showed physical signs of hemispatial neglect. I'm just going to define what that is. Hemispatial neglect is a neurological condition in which damage to one hemisphere of the brain is sustained. A deficit in attention to and awareness of one side of the field of vision is observed. It is defined by the inability of a person to process and perceive stimuli on one side of the body or environment, where the inability is not due to the lack of sensation. So hemi-neglect is always a perceptual abnormality. So it's not that there is paralysis of a limb or loss of sensation in any body parts. She also has the ability to generate eye movement to the left. It's just she doesn't have the inability to have the attention to and awareness of her left field of view. So most of the time, patients are unaware that they have a hemi-neglect. They can develop perceptual deficits in a visual field or perception of a body part. So for example, if you have a left hemi-neglect patient, they can ignore the left side of their body where they won't use it. They won't reach out to drink or they won't touch anything. Sometimes you have problems with them even dressing because they want to ignore the left limb and things like that. And then if you have a female that has this left hemi-neglect, she'll literally, and if it's affected in the area that controls her face, then she'll go to put makeup on in the morning and she'll literally not put makeup on the left side because she's going to ignore that left face. Not, she can feel her left face, she can talk perfectly fine, she has perfect motor control, but yet the attention to and perception of this body part is just not there. So those are, when you see those signs, you always think higher up. That's a cortical human function type of thing. It's more of the perception of who we are as people deficit. So this multiple sclerosis patient and the treatment goals. So we would want to increase her ability to walk and the prevention of falls. So since the patient has this left hemifield neglect and she has poor gaze holding in the left field, I'm going to start, and also the metabolic threshold of this patient would be much lower because she's had the disease for longer. So I'm going to start with something that's less metabolically demanding, and that would be reflexive eye movements. Reflexive eye movements, the VOR, the vestibular ocular reflex, is a reflexive eye movement. So one thing that's a good area to start in this type of patient would be using her right VOR. I can use a fast right head motion, and then I can put a target in her left field of view and just slowly shake her head in a no passive motion to create plasticity in the eye muscles that hold your eyes to this left side. Then I would eventually increase the metabolic threshold, and then you start doing saccades, pursuits, and all more extensive, intricate stuff. But you start low and slow, and then you just slowly increase up. Another important thing to address with this patient would be her gait pattern, because we know that she's not walking well. She's at very, very high risk for a fall. So another thing with her is I did this gait protocol with using SSEP, electrical stimulation. SSEP is basically just this type of frequency that's really good for activating more of your inhibitory centers in the brain. So you put the stim on a nerve that is the most superficial to the periphery, and then that nerve has control up centrally from the brain. So it's going to activate those areas that control that body part. I would also do vibration on the feet, legs, hip flexors to increase proprioception awareness of where her feet and legs are. Vibration is like a fantastic modality for at home, and if you're not able to get to a functionalist and get diagnosed, but let's say when somebody touches your foot, you don't know where your foot is, like you can't really perceive it, or if you have balance problems, putting vibration on your calves, on your quads, on your hamstrings, on the bottom of your feet is going to increase your brain knowing where that body part is. So through any process where the brain's not working well, eventually what happens is the maps of your body part that live in the parietal cortex, they start to get smaller and smaller, and they start to get inaccurate. And you could put a handheld vibration, a vibration plate, and it helps things like that, especially in the elderly population. So treatment goals in this patient is to increase her autonomy, her ability to walk, and the quality of life, decrease her risk of falls, developing depression, and cognitive decline. So looks like we're running short on time, so I'm going to try to go as quick as I can through this. Dysautonomia and positional orthostatic tachycardia is a severe problem in many, many people. I'm going to go ahead and play this video while I'm talking. So this patient came in with severe fatigue, lightheadedness, disequilibrium, and she was extremely anxious and just simply fearful about getting up and walking around her house because she constantly would feel unstable, like she was going to fall. She was no longer working, and she had to use a cane to walk just about everywhere. So if you notice with this in this eye movement video, she has a lot of ocular bobbing, like motion of her eyes, and that's because she has this increased tachycardia. Tachycardia is fast heart rate, so her trunk is moving, and it's causing this perturbation of her eyes as well. Now, I don't know if you guys noticed what just happened in that video. I'm going to go back just a tiny bit because I want you to grab onto this. So she's going to look to the left here. And you see when she looked to the left, her eyes went up and around to the left. She got what is called a cycloversion. So when she had left saccade, she gets left extorsion of the eyes. Well, instantly when I see that, I say, well, wait a second, there's something going on right there, because horizontal eye movers have no cycloversion. Cycloversion is a torsional aspect. The eyes kind of tort like that. That shouldn't happen. It'll happen in the up and down plane, like the vertical plane. It will not happen in the horizontal plane. So instantly I say, okay, that the muscle that's involved with that left extorsion is firing very, very high. And the reason why it's firing high is because it's not being inhibited by the opposing muscle from the other side of the brain. So in this patient's scenario, that instantly tells me that she has the left inferior rectus muscle. So in the left eye, her inferior rectus muscle, and in the right eye, her superior oblique muscle is stronger because she's getting this left extorsion. So she's got a high firing right cerebellum and left mesencephalic network. And that's going to give me a lot of input onto what I want to do with her next and how I'm going to fix this. So her treatment goals are activate the left cerebellum and right mesencephalon, increase trunk stability bilateral, fix pathological eye movements, recalibrate otolithic system, which is very important with dysautonomia. The otolithic system is the vestibular system portion that is very much involved with gravity, meaning when you go from sitting to standing to lying to running. This patient would also do well with balance exercises to get this patient walking. So moving on, this defines the positional or postural orthostatic tachycardia. I don't know how much time I have to review this, but dysautonomia is a really big prevalent thing because there's so, and especially female population, but the autonomic nervous system is a division of the peripheral nervous system that supplies smooth muscles and glands and thus influences the function of internal organs. It controls our heart rate, digestion, respiratory rate, pupillary responses, urination, and sexual arousal. Its divisions are sympathetic, parasympathetic, and enteric system, and has our hypothalamus and limbic system has major control on the organ function and constriction and dilation of blood vessels through the system. So dysautonomia is just simply dysfunction in the regulation of the autonomic nervous system. Okay, Lauren, do you want to pop in?
Sure, what's up?
Are we okay? Like it's 12:50. Should I jump to balance exercises?
I would say, mention these different types of things, maybe not go into all the specific detail, but, and then if anyone has any of their questions, please put them in now, and then we can address them. If we go a little bit over, it's fine.
Okay, perfect. Yeah. All right. So for a dysautonomia patient or a patient that has syncope is where they pass out and faint because they have these changes in blood pressure when going from sitting to standing, it's very important to do a tilt table therapy, and you basically incline the patient very slowly and hold them in these positions of gravity from lying to standing. And the reason why you hold them there is you allow your vestibular system to sort of attenuate these hyperactive responses. Gravity is a blessing to humankind, and it honestly activates it's our default network in the brain. It keeps us alive as human beings. It's really important. But we would do that with with a POTS patient or a dysautonomia patient. We would also do balance and at-home exercises. Number one, because we really need to get this patient walking more and the confidence up with the ability to walk, because a sedentary lifestyle is not going to facilitate novelty, and it's not going to facilitate brain health and things like that. To activate the dorsolateral prefrontal cortex and to increase emotional stability and decrease the fear and anxiety aspects seen in this patient, the balance exercises will go a long way for her. So this is a TBI and post-concussion patient, and I will kind of play this while I touch on a few things. This patient came in with depression, cognitive decline, and fatigue. Now, the second you see depression, it is instantly really important to understand that encouragement and positivity will go a very, very long way in their recovery process, and we're going to review an article here in a second. And some of the exam findings I'm not going to really go into, but the main thing with treatment goals, the first thing I look at is I say I need to fix any abnormal eye movement pathology, because the probability of their symptoms improving just with that is very, very high. And then you increase their cognition and memory by just adding in more of these combined exercises with saccades and memory tasks and anti-saccades. Okay, moving on here. Research supporting therapies that activate the dorsolateral prefrontal cortex. So this is a real big take-home point here. So we know that all brain injury patients have decreased activation of dorsolateral prefrontal cortex. So we know that we can help their symptoms by activating that area. So the dorsolateral prefrontal cortex is activated during balance and complex sensory manipulation tasks involved in postural control. Standing on one foot or in tandem stance would be a good example of these like complex multisensory balance tasks. Standing with eyes closed is another challenge. Standing on a foam pad, doing balance exercises will activate the bilateral dorsolateral prefrontal cortex. Great way to feed into that area. Here's the article we just referenced. Sensory manipulation results in increased dorsolateral prefrontal cortex activation during static postural balance in the sedentary older adults. And this study was done with the FNIRS study. So the conclusion of this, our findings highlight the involvement of the dorsolateral prefrontal cortex in maintaining postural control, particularly during complex sensory tasks, and provide direct evidence for the role of the dorsolateral prefrontal cortex during postural control of a clinical relevant measure of balance. Okay, love this article. It's really huge to set home that in terms of community, in terms of family, when a patient is suffering a brain injury, sometimes they say really messed up things to us, or they'll say things that trigger you and you want to argue back, or you want to get mad at them. And it's important to say, hey, at this time, they're not in the right mind state. You know, maybe they're real angry, their personality has changed. The best thing you do is just continue to encourage them and have this positive praise, because we see that there is a major correlation between depression, like patients that were depressed, they recover 3 years later, they're considered recovered from depression, and then their mom turns around and criticizes them, and they instantly relapse in the depression state. So this article is called "The Activation of the Dorsolateral Prefrontal Cortex in Response to Maternal Criticism and Praise in Recovered, Depressed, and Healthy Control Participants." The study suggests that people with a known vulnerability to depression, even when they are not depressed, respond differently than control subjects when they are confronted with the effective challenge. After being criticized by their mothers, fully remitted depressed participants showed a greater increase in their negative mood, along with significant failure to activate the dorsolateral prefrontal cortex compared to healthy controls. So we talked about how eye movement activates the dorsolateral prefrontal cortex. We talked about how multimodal balance exercise activates the prefrontal cortex, and also encouragement, praise, really making somebody believe in themselves activates the dorsolateral prefrontal cortex. So then kind of tying this into the global message we want to start communicating to people is the changes in mental health and physical symptoms after head-eye vestibular motion therapy in post-concussion patients suggest that therapy might have applications in other mental health scenarios, meaning that if anybody in any point in time is having depression, you want to start saying, hey, maybe go see a functional neurologist, or you know, there's physical therapists that specialize in vestibular and eye stuff that works well too. So patients reported a significant decrease in their symptoms and an increase in function after the head-eye motion therapy. TBI patients are at the highest risk for developing depression, so we need to start making people more aware of that. Going on into neurodevelopmental disorders, there's so many forms of neurodevelopmental disorders. These kids are totally different, have total different areas of their brain that work well and don't work well. Some of them, motor skill delay, Tourette's, OCD, dystonia, movement disorders, autism spectrum, Asperger's, attention deficits, dyslexia, sensory processing. They're listed here below. So mirror therapy is really fantastic. It's an easy thing to do as well. So if somebody has a paralysis, a dystonia, a hemi-neglect, ataxia means that they have the motor or they have the strength in their muscle, but it's the command going down to that muscle to control it that is disrupted. Tics, movement disorders, neurodevelopmental disorders. Mirror therapy is really fantastic. And basically what that means is patient looks into the mirror. If they're looking at their right hand, the mirror is going to show them an image of their left hand. So let's say they have paralysis of their left hand. The doctor is going to hide behind the mirror, move that left hand in a complex pattern, and also move the right hand. But the patient's going to look in the mirror and see this beautiful motion happening in the good hand and perceive it as being the bad hand. And that crossover will remap these motor cortexes to the body parts. Pretty phenomenal. Okay, antipsychotics and prostacods. I did Lauren, you want to chime in on, should I just keep going?
Maybe, maybe show this video and talk a little bit about it, but then I would skip to maybe the exercises then.
Perfect. The
And then we
balance
do have
exercise.
questions.
Okay, perfect. Okay, so this is a video that's going to give you a good example of what an antipsychotic is, and it's also I'm going to explain to you what a no-go task is. So if I were to play this video for a patient, I instruct them to look at that center black dot, and they're going to fixate on the black dot. When they see the dot, so that left dot just moves. I take my eyes to the right. That would be an antipsychotic. Then I go back to center. So that just moved. Now I'm going to go to the left and go back to center. So you ignore the actual stimulus. So you see how that just went black? That would be a no-go response. That means I stay center. That flashed again, the wrong motion to the right. I stay center. Now that's blue. I stay center. Now that's red. So that's normal. So now my eyes are going to jump to the left side and go back center. And that was red. I go to the right, go back center. I go to the right, go back center. So that's what an antipsychotic is. When something moves in my periphery, I saccade the opposite direction of the visual stimuli. A no-go response requires cognition to fire in and say, okay, wait a second, that target doesn't match what I should be looking at. So that's telling me don't go. So that means I stay center. So that's an example of what that is. And that's very much great activation into the dorsal outer prefrontal cortex. That's also both in Parkinson's disease and autism spectrum disorder. We see major overlapping pathology in antipsychotics. So that tells us that globally and a majority of neurological deficits, these antipsychotic tasks, memory guided psychotic tasks are affected. Okay, moving on into treating neurodevelopmental disorders. This is just showing that performing precise and accurate eye movement and performing go, no-go cognitive exercises provides stimulation into the cortical areas of reduced functional connectivity and has a high probability of treating neurological deficits in autism spectrum disorder. This is just an example. We're going to go ahead. I'm going to play this video because this is an eye-hand saccade exercise with go, no-go. So if you notice, I'm just hitting the target in the periphery. The no-go signal is when that the center flashes a difference. So I have to go back to center and hit it before I move on. So that would be no-go. That's an example of a way to incorporate that. And I'm also having saccades here, and I'm having to coordinate controlled motor patterns of my fingers, so I'm accurate on that target. Okay, this was just some more research. We'll skip to this. This is a memory saccade. This is also a cognitive distractor. So what I'm doing here is I have to remember this last digit that pops up. So it's a 12, and then I remember the location of the target. So now a target's going to pop up. I have to remember that location. It goes away. I get cognitive distractors. I have to remember the last digit. And then I have to hit the target location I remembered and then hit the last digit. So that's an example of memory-guided saccades with a cognitive distractor. And moving on, I'm just going to read this real quick. Concussion, TBI symptoms result in reduced functional connectivity in the brain. Every concussion and TBI patient has unique neurological deficits. Treatment has to be tailored to the individual strengths and weaknesses. Remapping neuron connections require precision and accurate forms of simulation. Cookie cutter approach fails when treating brain injuries. Athletes are a good example of having unique brain function acquired by mastering their sport. So once their brain, an athlete, or especially professional athletes, but even in high school, like if they've been playing the sport for a long time, once their brain function has improved in the office setting, it becomes very important to perform therapy and brain-based treatments and the environmental challenges of their sport, because their brain has developed really well and really good for whatever sport they're involved in. Recap of the dorsolateral prefrontal cortex. The dorsolateral prefrontal cortex shows decreased activation in a wide range of neurological disorders and is responsible for many symptoms felt in post-concussion syndrome. We have concussion, brain injury, neurodegenerative diseases, neurodevelopmental disorders, aging, balance problems, and psychiatric disorders such as depression. They all show a decreased activation pattern in the dorsolateral prefrontal cortex. So ways that we can activate the dorsolateral prefrontal cortex and recover from neurological symptoms: visual spatial integration and attention, temporal working memory, so challenging our spatial memory, eye-hand coordination, saccade, task, targeting, and motor learning, memory saccades, anti-saccades, and cognitive go, no-go tasks. I will also have Lauren send you guys a link to Precision Brain Center's YouTube site, because the videos I showed you of the anti-saccades and the NSI program, I'll have those videos on the YouTube channel so you can reference what they look like in real life on that channel. Complex balance exercises combined with sensory challenges and positive praise and encouragement is really important for activating that area. So this is just a review there, and benefits of balance exercises. So this study just showed improvement in Parkinson's disease with balance. Lauren was so kind to make you guys this wonderful PDF explaining a very simple, safe balance exercise that can be performed at home. She's put this all in a file for you guys to download. And here is the video. This video is also on YouTube, so you guys can take a look at that.
Dr. Cabela, in this video, I am going to demonstrate a balance exercise that you can perform at home. Quickly to go through, the main idea is you need to find a corner in your house that is...
I'm not going to play this full video, but you guys know it's accessible to you. So this is a breakdown, and Lauren also put this in that PDF for you on how to challenge yourself with these at-home exercises. And a lot of these exercises were taken from the standardized balance error scoring system and how we look at balance in a very quick, portable, cost-effective way. Love this study, and just to kind of summarize this meta-regression found that vigorous intensity is as safe as moderate intensity exercise, and it says that exercise frequency of between 2 and 3 times a week was associated with decreased mortality, whereas more than 3 times per week of exercise was associated with increased risk of being a faller. So this study was really looking at how severe fall risk are and the mortality rate and all the other problems that are developed after you fall and what ways to prevent it. And the biggest thing was that long-term exercises, particularly moderate intensity, multi-component training, balance exercises performed 2 to 3 times per week appears to be a safe and effective intervention for reducing the risk of being a faller. Also, if you're a crazy exerciser, you work out every single day, that's not good. It's actually associated with more risk of being a fall. So that's a big eye-opener in terms of understanding what the research is really telling us. So outcome measurements, I'm going to skip through some of this stuff. And this was our contact 106. So I didn't do so bad. I talked mile a minute though. But this is my contact information, and I'm just going to see if Lauren has any questions that anybody wants me to clear up.
Yeah, thank you so much. We do have a few questions, and we will be recording this webinar, so that's why it was okay for you to go a little bit longer, just because I want to make sure that we get the content. So some of the questions that we have are really primarily related to looking at the more recent diagnosis of brain injury versus the more longer term or severity of injury. So, an individual is talking about their particular situation with difficulty with balance, they're with their son, and difficulty with previous experience with functional neurologists, because it felt like it was more related to mild traumatic brain injury and concussion. Do you have any thoughts or discussion on kind of what the results or the outcomes of functional neurology looks like from a new injury versus, years ago, or more mild versus severe?
So in most cases, a more recent injury is a lot easier to treat. And the reason being is we used to recommend rest and then get back to play, but now you really don't want to be resting the brain for too long. You want about a week to 2 weeks max of low activity. But removing stimuli, meaning staying inside, not getting visual stimulus and not getting movement in your body, is not a good thing. Also, when you're treating something that's newer versus chronic, it's way easier to treat because the brain hasn't developed so many compensatory mechanisms. So a lot of times when I'm treating a patient, I have to break their compensatory mechanisms to allow them, because it's not good to fall down, right? So if my balance system stinks, I'm going to rely, if my vestibular system is bad, I'm going to rely more on my proprioception or my vision system so that I can walk around. But that's a compensatory mechanism. I still have a major deficit. So the more you have time to compensate, the harder it is to fix. So I don't know if, also keep in mind, every functional neurologist is not created equal, just like every medical doctor, every neurologist, every neurosurgeon is not created equal. So I think that, researching the website, the reviews, what type of conditions that functional neurologist specifically has treated and done well with is really important. Also, Dr. Carrick, they're trained under Dr. Carrick, and they've had a fellowship under that fellowship was really difficult to get into. So there's not so many of us out there that really have that clinical expertise with Dr. Carrick. So that's also a good indicator that that functionologist will be able to treat not just TBI and not just TBI for 6 years, but neurodevelopmental disorders, movement disorders, neurodegenerative disorders, because it's all the same approach, Anything else?
Thank you. So just to kind of summarize, so it sounds like that the main difference between treating an individual with a more mild or concussion versus a severity is mainly just trying to navigate through those compensatory strategies, and so that it's not necessarily a excluder for services in terms of functional neurology if you have a more severe injury, or if it's from many years ago. It complicates the treatment a little bit more. Is that correct in what I'm hearing?
Yes, absolutely. And the biggest thing too is every patient is so different. They can look identical or they can complain of the same symptoms, and yet their brain function is going to be globally, massively, very, very different. So understanding that, and also understanding that every patient, it's always, the question comes down to, what is your biggest problem and how can I as a clinician help you the best? So some people, it's really important for them to be able to just simply get up out of their chair and be able to walk around or stand up for 30 seconds. That's a big deal for them. Other people, they're working in a corporate CEO job, and it's a big deal for their short-term memory to be increased. Everybody has different needs, and I think when you go to the doctor, with whether it's your son or whether you're the patient, it's really important to communicate what your priority is in treatment and say just outright, do you think you can fix this? And so yeah, you're right on with the summary there, Lauren.
All right, cool. And so what about, we talked a little bit about individuals that have difficulty with movement, or a little bit more challenges with balance and things like that in terms of vestibular system. When you're working with someone that experiences paralysis, how does that, potentially from the waist down, that was one of the questions, touching on one of the questions that was mentioned, is there a different approach to treatment, or is that an excluder for treatment? How can we look at the exercise a little bit differently when we're looking?
Is that patient wheelchair bound, or are they walking? Like, is it a little bit of paralysis? Is it due to spinal cord injury? Like, there can be so many factors, presentation. It could, peripheral neuropathies can cause some forms of paralysis. There's all different pathologies that can, and no, it's not any excluder type of thing. Meaning little subtle things can help somebody who's completely wheelchair bound with cerebral palsy and they have a spastic, things that look very difficult to help. Being able to help that patient get rid of the spasticity in their limbs and they can put on pants, that's a big deal for them, right? So no, it does not rule it out, but it could. You know, that's the biggest thing. Is the easy stuff is the red flags to say, okay, this patient is not, it's not a good indicator for functional neurology.
Okay, so it sounds like it potentially is, that is very much a case by
Oh,
case basis, and also
yeah.
a very, neurologist by neurologist basis.
Yep, exactly.
Okay.
And
Okay,
if
yeah,
any of these people have specific questions that they want to email you, you can email it over and I will answer it very directly based on their specific scenario, because I'm sure people don't want to share on a webinar what they really have going on, but I can certainly address those.
yeah, I can definitely get you, and I'm sort of summarizing questions too, so I can get you their information, because this particular individual, did share that it was primarily a wheelchair, uses a wheelchair, and paralysis from the waist down. So it sounds like that would be a case by case
Yep,
basis, and so I can maybe connect you guys.
absolutely.
And then I had a quick question, just to finish this off, I guess. You had mentioned vibration being so key when you're talking about the case study related to multiple sclerosis.
Yeah,
And
and
I
it
was
actually,
curious, what's up?
go ahead, Lauren. It's not just multiple sclerosis, it actually relates to many, many disorders. So yes, I love this question. Ask it.
Yes, yeah. So I was, because I recently was at a paralysis rehab center for individuals that experience paralysis, and so they were using a similar vibration technique to stimulate the nerves and the muscles and kind of get everything going.
Yeah, so that
And
what that's called, the nerves in the muscle and the joint position sense, that's called proprioception. So like I was telling you before, in order for us to stand upright in gravity, we're getting information from our vision, we're getting information from our vestibular system, the inner ear and gravity, and we're also getting information from proprioception. And proprioception is a system of joint awareness, muscle awareness, nerves of the whole entire body. So since we know that vibration has a massive impact on that proprioceptive input, it also, I wish I had a picture of the homunculus, but the homunculus is an area of the parietal cortex. It's a strip that controls the sensory area in the body and has a map of all the body parts that correlate to a specific area. And then in front of that, you would have the motor network, which is the frontal cortex, and it's all the motor generators for every body part. So what's fantastic about vibration is you put it on a muscle or a joint, and not only do you get these proprioceptive tracts that fire into your cerebellum, but it's going to fire right up to those cortical areas where the homunculus is, and it's going to activate that specific brain structure correlating with that body part. So whether it's a hand and the muscles of the hand, but having body map awareness, knowing accurately where your body parts are in space is huge, because we see Parkinson's. Like if you have a tremor in Parkinson's disease, you drop things, you can't drink a glass. Well, guess what? You don't know where your hand and limb are in space. So ideally, adding vibration to that hand and limb is going to help that tremor. It's going to bring more health to the substantia nigra, and it's just going to, it gives autonomy to people, and it's super easy, and it's probably the least invasive, meaning like if you start feeling dizzy, you know, hey, okay, probably should do less intensity of vibration. But if you don't feel dizzy, then you know that it's safe to continue doing vibration. It's very non-invasive.
okay, and so I'm thinking, like, I've been to stores and things like that. They have like the vibrating neck massagers or like back massagers. Is that something that that would be really accessible to people, that they would be able to use
Yes.
this?
And also, there is like this home medics company that you can order, like eBay or Amazon. They have handheld little vibrators. There's a gray one out there that I always send the link to my patients to buy, but it's really easy to put anywhere on the body. You put it on your thighs, your hamstrings, your legs, your arms, your back, your neck. If somebody has a like real spastic neck, that's going to be terrible in the long run for their brain health. So if your neck is real tight, your neck information fires into the brain globally extensively. So nothing can be wrong with you now, but in the future, your brain goes down south. So getting a handheld vibration and putting it on those neck muscles is fantastic. And like you said, I love that idea of it being very accessible.
Yeah. Is that something that you do, for like 5 minutes each day, like twice a day?
You
Like
got
how
it. So
often?
you want to start with a low time frame, meaning 5 minutes is perfect. And the brain likes frequency. So the first suggestion would be to try to do it for like, and even starting off, if you're not sure, especially in the neck, you might only want to do for like 1 minute. So 1 to 5 minutes, and you're going to want to repeat that 3 times a day. So if on the first day you do it and you feel fine, then you'll continue with that progression. Then you can progress to a little bit longer with certain things, and you can add different body parts. And if you don't know where your deficit is, like if you don't have a paralysis or a paresis on a specific limb, then you sort of want to do both sides of your body just to be safe. And then work your way up. Now, if you try that 1 to 5 minute idea and you don't feel good, or you feel dizzy or queasy, or just you get some sort of symptom, then you need to do it for like 30 seconds and then slowly increase the amount of times you perform that exercise that day. And the really good recommendation when it comes to just different therapies to do at home, the balance exercises, all that stuff, is to slowly increase the intensity of the exercise you're doing and do it about 3 times a day if possible.
Okay, excellent. What about the vibrating foam rollers? I guess that would.
I don't have those in office, but is that basically like a foam roller that vibrates?
That's what I'm thinking. That's one of our attendees. They had asked about it.
Yeah,
Yes.
I like that a lot.
Cool.
And
Cool.
obviously, if people are recommending, especially if it's like a physical therapist or occupational therapist, they'll know what's safe and what's not safe. So, I mean, as long as it's in a they're not standing on the foam roller, right? Like they're using it on their back or maybe their leg to get out the spasticity of their leg. Adding vibration to that foam roller is a brilliant idea. So that's pretty cool. I have to look that up.
And I believe the last question that we have is really, do you have any general thoughts on brain surgery and late stage radiation effect resulting in right ventricle being twice as big as the left?
So they had a tumor removed. And did they have radiation on their brain, or they have it for another form of cancer?
The tumor is removed, I believe she said yes. On the brain.
In her case, so she probably has a little bit of hydrocephalus, and it changes the pressure within your ventricles and things like that. Her case, she would be great to kind of tell me what she's experiencing, what she has. One of the big things to remember always is that doctors are human, right? So be very careful sometimes when you're given a diagnosis, you're told this. That doctor isn't God. It's not the end all be all. And you have every right to research things, to look into your options. And nowadays, I'm a very scientific person, but if somebody really believes in us and it's something that's maybe not supported by science, the belief in that is huge, right? And so it could in a certain patient. Would I ever recommend it for everybody? No, absolutely not. But it could in a certain patient make them better. So at the end of the day, if it makes them better, then I'm like, hey, I can test this and I can see that this is making you better. Fantastic. You can keep doing it. So knowing that, it's really important for anybody in any severe situation where it's just you lose your hope and you get down on things. Not every doctor is going to be correct on what they're saying your treatment options are. So I would love for someone like that, I would love for them to write up what they have going on and kind of their specific questions. You can email that right over to me or Nisha, and I'd be happy to get back to them.
Okay, perfect. Yeah, I'll definitely, I'll probably get a list of the different questions. I'll send that out to viewers, your YouTube link, the slides potentially, any of the handouts, a link to maybe that Homedics massager that you mentioned.
Yeah, I was actually doing that on my phone. Yes, so I will email you that link so that you have that. It's perfect.
Perfect. And then I'll send you a few of the questions that we've talked about and connect you with the individuals that were asking a little bit more specific questions. But overall, I really appreciate you taking the time to share your knowledge and information with us today. And really, I just found it really great. Like I said, we'll have this recorded and accessible to individuals, and I hope that everyone else found it as entertaining and just really great information. Please fill out that survey and let us know what you thought, what you want to learn next, and happy Brain Injury Awareness Month, and get out there.
Thank you so much for
Awareness.
having me, Lauren. It's a pleasure.
Yeah, thank you so much. All right, everyone have a wonderful day.
Bye.
Bye.